Okay. Today, our topic is about physiology of tears. This is the content of our lectures today. The tear film is a thin fluid layer covering the ocular surface. It's the interface of the ocular surface with the environment. Tear production, including evaporation, absorptions, and drainage, are responsible for dynamic balance of the preocular tear film. Homeostatic balance leads to stability of tear film, which makes possible to perform its function as a lubrication, nutrition, and protection of ocular surface. We will go briefly about the anatomy of the lacrimal gland and the drainage system, as well as the neurologic innervation of the lacrimal system. Then we'll go to the main part of our topic. Main lacrimal gland is composed of large orbital lobe and smaller palpebral lobe. These two lobes divided by the lateral aponeurosis of levator bilateral expansion of levator aponeurosis muscles. The gland located within a fossa of the frontal bone in superior temporal orbit. As you know, the ducts for both lobes passes through the palpebral lobe. That's why it's not recommended to take a biopsy from the palpebral part of the lacrimal gland. The lacrimal gland excretes serous watery component of the tears. Other accessory lacrimal glands, we have the gland of Cruz located at lateral part of the fornix, as you can see in the photo. Glands of Wolfram are another type of accessory lacrimal glands, and it's larger than the gland of Cruz. It's located near the central part of tarsal plates. Both glands secrete serous component of tears and account for about 10% of total lacrimal production. Both glands cytologically identical to main lacrimal glands, and both again receive the similar innervation. Talking about goblet cells as a part of mucin secretion, it's located in all region of conjunctiva and secrete mucin component of tears. It's include the glands of, as well as glands of Mans located at limbal conjunctiva and secrete again the mucin component of tears. The third gland is a crypt of Henle located at upper and lower third of conjunctiva and secrete mucin. I'm not sure if it's clear for you here in the photo, crypt of Henle and the both accessory lacrimal glands and the goblet cells. For the drainage system, I'm pretty sure almost all of you know that it's divided to upper and lower puncti, connected to lacrimal canaliculi, and both connected in some patients to the common canaliculus, then drain to lacrimal sac, then the nasolacrimal duct system. This is, in brief, the neurologic regulation to the lacrimation. It's a pretty complex neuroinnervation to the lacrimation. We have the afferent sensory fiber through lacrimal nerves, efferent parasympathetic and efferent sympathetic fibers. It's clear in this table that parasympathetic give the most supply to the lacrimal system, and the sensory by the afferent lacrimal nerves. About composition of tear film, it's mainly composed of a 3 protein factor: albumin, globulin, and lysozyme. Immunoglobulin A is the most prominent immunoglobulin, while immunoglobulin E increases in patient with allergic conjunctivitis. Immunoglobulin M increase in patient with acute infection. Lysozyme constitute 20% of all proteins, and it's the highest concentration and compared to blood component. Electrolyte, including potassium, sodium, and chlor, has a higher concentration in tear film compared to blood. This is the physical properties of tear films. You can see that the thickness is around 4 to 8 micrometer. The volume is between 4 to 13 microliter. Rate of secretion is about 1.2 microliter per minute, and it's decreased with aging. Turnover rate is 18% per minute. Refractive index is 1.357. pH of tears is more toward alkaline side, 7.3 to 7.7. Osmotic pressure is 0.9%. Temperature 30 at cornea and 35 at limbus. Oxygen tension is 40 to 160. About the tear film structure and function. Tear film is responsible for ocular surface comfort, mechanical, environmental, and immune protection, as well as epithelial healing, and it's formed the smooth refractive surface for vision. Its recently proposed structural model, it consists of 2 layers, superficial lipid and mucin aqueous glycocalyx gel with decreasing mucin concentration as you go from epithelium to lipid layer. Some authors say that the tear film is single unit that act like a fluid shell. This photo can help you to understand the structure. As you see, the superficial layer is the lipid layer. Then the main bulk of the tear film is the intermediate layer, which is the water aqueous layer. Then the deepest layer is the mucin layer attached to the microvillus of epithelial cells. This table will make the understanding the tear film structure and function easier. Tear film layer, lipid layer, which is mainly from meibomian gland. It's formed the outer layer of the tear film. It's also minimized the evaporation of water from the eye. It's isolate the ocular surface from the environment, improve the stability of tear film, provide a smooth refractive surface. It's limit the contamination of ocular surface from particles or microorganism. It prevents the tear contamination by skin lipids. It limits the aqueous layer surface tension, and it's counteract tear overflow onto the skin. So any defect on the lipid layer will affect one or more of the function which just mentioned. Aqueous layer, it's constitute roughly 90% of tear film volume. It's lubricate the ocular surface and wash away foreign bodies and contamination. It's nourish the avascular part of the eye, which is cornea, and it's provided it with oxygen, protein, and inorganic salts, include protein, lysozyme, lactoferrin, and immunoglobulin, and a glycoprotein responsible for antimicrobial activity. It includes the growth factor, vitamins, and electrolytes necessary for ocular surface health and epithelial integrity. It realign corneal microirregularity, which play a main role in maintain the refractive power of the cornea. Regarding mucin or mucus layer, it's formed the glycocalyx over the ocular epithelium that prevent pathogen adhesions. It binds water, which is the aqueous middle layer, to hydrate and lubricate the ocular surface. It's reduce the friction during blinking, clear the surface of pathogens and debris, contribute to tear stability, take part in regulation of epithelial growth and epithelial healing. It might be involved in cellular signaling. Regarding type of tears, we have the basal tears, the main important, most important type. In healthy eyes, the cornea kept wet and nourished by basal tears. They lubricate the eye and keep it clear of dust. It's typically body fluid with a salt content similar to blood plasma except for potassium, sodium, and chloride. Usually in 24 hours period, 0.75 to 1.2 grams of tears are secreted, and this rate usually slow with age. Reflex tear result from irritation of the eye or with foreign bodies or any irritated substance. Reflex tearing is important because it supplies such essential components like endothelial growth factor and vitamin A, whose deficiency may cause squamous metaplasia. Basic and reflex can be distinguished from each other by Schirmer tests. There is no reflex tearing in Sjogren syndrome because of destruction of lacrimal glands. Third type is psychic tears, which is increased lacrimation due to strong emotional stress, suffering, or physical pain. Regarding tear film dynamic, balanced tear film production and elimination is crucial for its integrity, stability, and right osmolality. Tear film production is a complex process controlled by various factors, main and accessory lacrimal gland, ocular surface structure including cornea, conjunctiva, eyelids with meibomian glands, and the interconnecting nerve, both sensory and motors, which all previously mentioned. Tear elimination proceeds as evaporation, drainage, and absorption. Higher evaporation is the reason for tear film thinning and instability and hyperosmolality. Tears outflow through the lacrimal drainage system remain the main way of its elimination. With each blink, tears with contaminations are moved toward the lacrimal puncti and next due to negative pressure created in lacrimal drainage system to the lacrimal drainage tract, and finally to the inferior meatus at the nose. Some studies noted reduction of tears production in patients with impaired drainage that highlight the importance of this process in the model of tear dynamics. At least absorptions, process necessary for proper tear film dynamic. The tear absorptions is most prominent by the epithelium of the cornea, conjunctiva, and mainly by nasolacrimal duct epithelium. I found this photo illustrate the tear breakup test. Most of you doing tear breakup test as a first examination test for patient with a dry eye. I found it helpful to understand why it's happened. I'm not sure if it's clear or my pointer is clear. This is the tear film. It's underwent evaporations. It gets thinner and thinner with time. The lipid layer will migrate through the aqueous layers to the mucus layer. Then here the osmosis will change, and the deepest layer will become hydrophobic due to a migration of lipid layer from the outer surface to inner surface, which cause hydrophobic change in the content, then ruptured of the tear film. And this what happened with this test. Usually it should be more than 10 seconds, 10 to 15 seconds is the normal. What is less than 10 is abnormal. We'll come to the test by end of this lecture. Here, the influence of various disease and condition of tear film. This is the clinical, this is the important clinical application of our topic today. Lipid layer alteration is the deficiency of the outermost lipid layer, and it's a reason of more rapid evaporation. The most common reason for lipid layer deficiency is the obstruction of meibomian gland or dysfunction of meibomian glands. By atopic local changes, chronic blepharitis, chemical agent, tobacco smoker, or diabetes. Again, another reason for disrupt lipid layer is insufficient protein intake, as either malnutrition or malabsorptions by in bariatric patients. Androgen deficiency due to aging or anti-androgen therapy, or congenital impairment or even absence of androgen receptor. Some incomplete blinking is another reason for disturbed distributions of lipid layer. Some medicine also contributed to lipid layer alterations like isotretinoin, which decrease the meibomian gland secretory function, in opposite to botulinum neurotoxin A injection, which seems to increase lipid layer thickness. Aqueous layer disturbance is the most common reason for dry eye. It's classified to two groups, Sjogren syndrome and dry eye, and non-Sjogren syndrome dry eye. Sjogren's syndrome, it's a rheumatic autoimmune disease in which exocrine glands, salivary and lacrimal, are involved, result in clinical symptoms of both dry mouth and dry eye. Sjogren's syndrome can be primary or secondary. Primary without any autoimmune systemic disease, and secondary, which is associated with rheumatoid arthritis, systemic SLE, and other autoimmune diseases like polyarthritis nodosa and systemic sclerosis. Non-Sjogren dry eye, it's reduced tear secretion as a result of senile hyposecretion. Can be also due to lacrimal excision, lacrimal duct obstruction, immune lacrimal gland damage by sarcoidosis or lymphoma. Can be due to scarring condition of conjunctiva, which affect the goblets or gland, accessory lacrimal gland, which might be caused by bemphigoid, chemical burn, or trachoma. Corneal hypoesthesia is another reason for aqueous layer disturbance. And it might be caused by corneal refractive surgery, excessive contact lens wearing, herpetic keratitis, and trigeminal neuralgia. Some medicine also can be contributed to aqueous layer disturbance, including beta blockers, antihistamines, antihypertensive, and anti-Parkinson's. Regarding the last layer, the deepest layer, mucin layer deficiency, it's disturbed related to the deficiency in goblet cells, and it can be related to insufficiency of vitamin A, as either by malnutrition or malabsorption due to GI disease or any diseases affecting the liver, pancreas, or in patient with or alcoholic patient. It can be also caused by destruction of goblet cells by cicatricial conjunctival diseases, Stevens-Johnson syndrome, trachoma, graft versus host disease, thermal and chemical burns. Also medicine, some medicine can affect mucin's layer, like mycolytics, antihistamine, and the preservative and topical medication, which might alter the mucin or modify the mucus layer of tear film. Multi-layer disturbance sometimes happen that the patient have more than one layer disturbed. Although 3 layers of tear films are investigated, all of them remain in strict dependence of each other and many conditions can cause disturbance of the whole tear film. Aging can cause decreased tear production. Eyelid issues, including eyelid incongruency as entropion, ectropion, eyelid irregularity, exophthalmos, and epitheliopathy. Hormonal changes, androgen and estrogens, can affect multi-layer of the tear film. Neurologic problem, both afferent and efferent part of reflex loop. Other factor can play a role: environment, dryness and humidity, visual display terminals, including excessive use of iPad or mobile, which affect the frequent blinking of the eye, and ended by disturbed lipid and aqueous layer. Some medicine, both topical and systemic, can also affect multi-layers of the tear film. Preservatives and the topical ocular medication can affect as well. This table can help you in managing or approaching patient with a dry eye. On the left side, you will see the symptoms that most of patients with dry eye will complain of: discomfort, itching, burning sensation or foreign body sensation, pain and photophobia. Visual fluctuation, especially during reading, and tear film instability, which might cause potential damage of ocular surface and epithelial defect. Signs during examination: you will pay attention for eyelids, for blepharitis, meibomian gland dysfunction, trichiasis, symplepharon, conjunctiva, including hyperemia, keratinization, persistent inflammation, which conjunctiva sometimes stained with lissamine green and rose bengal. Tear film debreezes reduced meniscus level, instability or reduced breakup time, elevated osmolarity and level of inflammatory mediators. You can see also, you can assess the cornea for epithelial defect, dyeing with, which can stain with fluorescein, filaments and presence of mucus clumping. Potential complication of dry eye, you can sometimes find it in severe grade for dry eye, like persistent epithelial defect, keratomalacia, corneal perforation, and corneal ulcer. This table, I find it to be helpful for resident for approaching patient with dry eye, dividing the dry eye to aqueous deficient dry eye and evaporative dry eye. Aqueous deficient dry eye, including Sjogren, dry eye primary and secondary, or non-Sjogren dry eye, which include lacrimal deficiency, lacrimal gland obstruction, reflex plaque, and systemic medicine. Regarding evaporative type of dry eye, there might be an endogenous reasons, as we mentioned before, GI diseases, pancreatic diseases, diabetes, or alcoholic patients which affect the lipid absorptions, meibomian gland dysfunction, disorder of lids and lid aperture, low blinking, either by neurologic diseases or due to excessive use of iPad or excessive reading. Systemic medicines also play a role, as we mentioned before, isotretinoin and botulinum toxins. Exogenous reason for evaporative dry eye, excessive contact lens wear, ocular surface disease, topical medicine, vitamin A deficiency. Keeping this, try to remember this table in approaching your patient. So you will keep clinic by history and examination, looking for the reason. It's really important to know the reasons of dry eye by history and examination. Then you approach the patient accordingly. This table shows you the diagnosis or the traditional and emerging testing of patient with dry eye based on symptoms and the objective, test objective. If you're looking for symptoms, you can questionnaire the patient or by history. If you're looking for tear volume, Schirmer tests will help you. And tear meniscus, sometimes fluorophotometry if it's available in your institute. Tear film stability, which assessed by tear breakup time, and interferometry as well. Tear turnover rate and tear clearance can be assessed by fluorescein dye disappearance test. And the tear film composition, which assesses the osmolarity and the presence of biomarkers, presence and level of biomarkers. Corneal evaluation by fluorescein staining. You can assess the degree of dryness by presence of CED and SPK. Epithelial thickness as well can be evaluated by confocal microscopy can be used as well. Conjunctival evaluation by staining with rose bengal and Leishman gris. Biopsy and impression cytology can be used as well as confocal microscopy. This is for evaluation of conjunctival dryness. Lid evaluation, it should be done with slit lamp with the expression of meibomian gland and assess the blink rate. Emerging test is meibomiography and is not available in all hospitals. Sjogren test. If you think that your patient is having any systemic disease, you should send him for serology test and combination of signs and symptoms. And sometimes they need biopsy for lacrimal gland. Last but not least, I found the This slide is helpful for the resident and fellow as well. It's a clinical guidelines for treatment of a dry eye disease at KKISH. It's the most updated one. It shows you the history taking and examination. I recommend you to follow these guidelines in assessing and treat or managing patient with dry eye. It shows you the history and examination and grading the patient to mild and moderate severe and all the required tests. And finally, the treatment based on severity of dry eye. This is the reference of our topic today. Thank you all for being patient.